Welcome to this lecture series from the Neurosurgery Research Listserv on neurosurgery for general practitioners, ER physicians, and pediatricians. Today, we have a very important lecture on how to avoid diagnostic delay in pediatric brain and spine tumors. And we are fortunate to have Dr. Ibrahim Qaddoumi deliver this lecture. Dr. Qaddoumi has for several years now campaigned to reduce diagnostic delay in these tumors, not only nationally in the US, but also globally. In fact, it was Dr. Frederick Boop, who was the former president of both the American Association of Neurological Surgeons as well as the International Society of Pediatric Neurosurgery, who had kindly recommended Dr. Qaddoumi as the best physician placed to deliver this lecture. Dr. Qaddoumi is a pediatric neuro-oncologist. He is based at the St. Jude Children's Hospital in Memphis. It is the preeminent hospital for childhood cancers in the world. So it is indeed an honor and privilege to have Dr. Qaddoumi give us this lecture. As we all know, any tumor, and in particular tumor in a child of brain or spine, is tragic to the parents, to the child, and any physicians who manage these kids. If there is a delay in diagnosis, that can risk poor outcome. When there is a delay in the diagnosis, as often is the case, then it can add further emotional turmoil to the parents and the physicians who had been involved in any delays. This can also have legal ramifications. So it is crucial that there is education, availability to education to avoid these delays in diagnosis of brain or spine tumors in children. And I'm sure that we will all benefit from this lecture from Dr. Qaddoumi. Thank you for attending, and thank you in advance to Dr. Ibrahim Qaddoumi for this lecture.
Good morning, good evening, everybody. Thank you for the opportunity to present again to the neurosurgery team. And I appreciate the opportunity, and this is a great interest of mine. And I know this may not be new for neurosurgeons because you deal with this problem, but I hope this can help you with your local pediatricians, internists, and primary care physicians. These are my conflict of interests. And the objectives of my talk are really avoid unnecessary imaging. I'm always worried when I work on these projects that I'm going to cause panic attacks and people start doing unnecessarily imaging. This is really very dangerous for the patients and the healthcare system. For me, the most important is to take good history, good exam, and good follow-up, because a lot of times we give, as pediatricians or internists or even neurologists or ophthalmologists, we give these soft diagnoses and we're not sure about it. Please make sure that family and the patient are aware to come back to you when these diagnoses are not improved. So make always instruct patients for follow-up. Also, I want you to think outside the box. We always teach brain tumors as a typical presentation of the triad of nausea, vomiting, and papilledema. We always teach that back pain is normal in adult population, which not the case in children. Also, I want you to think of diagnostic imprinting, as I'm going to talk about this more and more, because this is a major issue. And once you give them wrong diagnosis, it really sticks to the patient, as I'm going to show you, especially if this wrong diagnosis is a psychiatric condition, and especially if the patient is female. More objectives of my talk is really to emphasize one major point, is that most of childhood tumors are low-grade gliomas. In fact, most of tumors, brain tumors in adult and children are low-grade tumors. Not necessarily low-grade gliomas, but low-grade tumors all behave the same. And we have to always teach this to our medical students, residents, especially in the primary care physician. I want also to emphasize good communication, as I indicated earlier, for the follow-up with patients, parents, and radiologists and other specialists. And if you order imaging, please make sure you order the proper imaging and you talk to the radiologist. Again, keep in mind diagnostic imprinting, and once you label a patient with a specific diagnosis, it will be hard to change it. Again, I want to emphasize the need to avoid unnecessary imaging, because imaging has its risks on patients and healthcare systems, and also finances, especially in developing countries where economics are already strained. But also keep in mind that if you do the wrong imaging, you really label the patient with negative brain tumor, and this will cause even further delays. This will be the outline of my talk, and I started with the objectives to emphasize my talk. And I wanted to emphasize the major points of my objectives about avoiding unnecessarily imaging, keep in mind diagnostic imprinting, avoid the triad of nausea, vomiting, and papilledema as the major representation of brain tumors, and always think that most common brain tumors are low-grade tumors. The problem, as I hinted at, is like that the emphasis on the triad. I know I'm repeating myself, but I cannot emphasize it enough. And I will show you more cases like this. And it's this brain tumors in children, and I think young adults also, it's unique because it's one of the few diseases where parents do better than physicians. I'm aware of at least 4 studies where parents suspected something before physicians. And one of the other main problem is because most of these tumors are low-grade tumors. Even if we do a bad job, the patients don't die, which make the problem underestimated, because we always worry about death more than anything, but we don't understand the impact on patient functionality and being a productive member of the society. Just to show you, like different studies showed that brain tumors continue to be one of the worst tumors to be delayed diagnosis. And I really believe it's about education, education, education. One of the things I teach my medical students and residents and fellows And I know this is not for a neurosurgeon, you all know that, but that's an exercise. It helps them deliver the point. I tell them, what's the first diagnosis that comes to your mind when you first hear brain tumor? And many of them think of these tumors, and some, if not minority, think of low-grade gliomas. Again, pilocytic astrocytoma alone is more common than any of these tumors I mentioned earlier. One of the things I think contribute to the problem, glioblastoma multiforme, is always used as the poster child of CNS tumors, especially when a famous person dies of this. I call it the senator's syndrome. And every 10 years, a famous senator dies of a glioblastoma. And usually their diagnosis is acute. They get diagnosed within a few weeks. And then there is subacute deterioration into death, unfortunately. And that emphasizes the concept we have in mind, that brain tumors are acute diagnosis, and the patient die within a few months, within a short period. And I'm one of the people who used to tell my patients when they ask me, I'm internist and pediatrician, by the way, when the young adult or the patient, the children ask me, do I have, the parents of the children ask me, could it be a brain tumor? And I used to say in a condescending way, if you have a brain tumor for 3 years, you should be dead by now. Sorry, by now. This is a study we did from SEER data, which includes about 17 states who contribute their data to this cancer registry. And you can see the majority of the tumors are low-grade gliomas. Again, this does not include other low-grade tumors. This is a more accurate data even, where it affects, it looks at brain tumors only, and it includes adults and children. You can see that even in adults or the whole population, the majority of the tumors are low-grade tumors. 71% of the brain tumors are low-grade tumors. That includes low-grade gliomas, pituitary adenoma, meningiomas. So we have to think outside the box of the triad of morning vomiting, morning headache, and papilledema. Again, we looked at this in one of our papers, and we reviewed the literature. And this is some of the issues that affects brain tumors in children. It's really a global problem. It's not only developing countries, it's even in most advanced countries. It's really not about access to care. It's more about education. Even in countries like UK, with everybody has access to primary care, there was significant delay in diagnosis, and that's why they started the Head Smart initiative. And unfortunately, the literature does not address all causes related to delayed diagnosis. And we always have to keep in mind some of the underserved population or unbelieved population, like women, the poor, and also patients who are labeled as psychiatric. Again, I'm not saying every psychiatric patients have a brain tumor. All what I'm saying is good history, good physical exam, and good follow-up. I want to emphasize diagnostic imprinting. It's in the title of my talk, because once you label a patient with a diagnosis, most of the time people will follow you for a while before they start questioning the diagnosis. And again, we have to emphasize that most of brain tumors are low-grade tumors. I'm sorry, I'm repeating myself, but I cannot emphasize these points enough, because that's, I think, where the paradigm shift will happen, and we'll start thinking of brain tumors in a different way. I want to emphasize psychiatric and behavioral, because we recently had a nice paper about this, and I'm willing to discuss it offline. I'll put my email at the end. But it's really important because, for example, anorexia nervosa. There was a recent study by Madhusisen, a nice, good psychiatrist who's interested in brain tumors also. And he found that significant number of patients who have anorexia nervosa, and keep in mind, these are young adults or teenagers, have midline tumor. And think of anorexia nervosa and its counterpart in the young children, diencephalic syndrome. Every year we see few cases of diencephalic syndrome where the patient had every workup except imaging because people don't think of a brain tumor. Although I was taught, I don't know what's the medical teaching now, that one of the causes of failure to thrive is midline tumor, but we don't think about it. And psychiatric and behavioral presentation are important because there is a national shortage of psychiatric experts or psychologists, and this shortage is even worse in developing countries. I always talk about developed countries because I'm from a developing country and my main work is in global also. The impact of delayed diagnosis, not necessarily on life. This is a study we did, and you can see that 90% of children are alive for 11 years. Very few tumors or cancers have this good outcome, but the impact on functionality is major. And in our study, we wanted even to compare grade 1 to grade 2, which are both low-grade tumors, low-grade gliomas, and we found the difference in PSI. PSI is a pre-diagnostic symptom interval. It's another way of saying how long it takes a patient to be diagnosed. So grade 1 have longer PSI, and older children takes longer to be diagnosed. And one of the interesting findings is that progressive disease is associated with longer PSI. And I think that's indirect indication that the longer the patient gets diagnosed, the bigger the tumor and more infiltrative. And there is also more seizures if you have longer PSI. Brain spinal tumors, like other studies from UK, Israel, and other countries, show that spinal tumors are the worst of the worst. And it makes sense because part of our teaching, I'm one of the people that it's normal for people to have back pain because most of the third of the population have chronic back pain. But again, children are not tiny adults. It's okay for me to have a chronic back pain, but I don't think it's okay for a 6-year-old to have a chronic back pain. So we reviewed the literature in our paper, and this is a summary of causes of delayed diagnosis. I hinted at some of them. And so I want to emphasize one point is disregard of parental reports and concern. When I was a medical student and there was a pandemic of kids dying of dehydration, the WHO came with this amazing diagnosis of dehydration to force physicians to give children to start immediately on oral hydration. It was diarrhea definition is what the mother says, not what you think. Again, I'm not dismissing that some parents are over anxious or over reporting, but we really have to try to believe the parents. Again, pediatric medicine is not like adult. A lot of times we see adult adult patients come to the ER with what we may call social presentation. They want to run from their misery or life struggles or family struggle, and they come to the ER to be admitted for chest pain or heart or pulmonary embolism or other what we may call fake symptoms. In children, it's not the case. There is no benefit for a mom to leave in the middle of the night to come to the ER with a crying child. Again, I'm not saying image every patient you see in the ER. All what I'm saying, take good history, good physical exam, and think of brain tumors possibility and ask for follow-up. Other things that also having a good neuro exam does not mean the person does not have a brain tumor, because as I said, these are low-grade tumors and they can take forever to grow, and this brain plasticity kicks in and functionality compensate. And also the location may not cause focal neurosymptoms. The patient may have only visual field deficit, and that's something that we don't examine. The patient may have torticollis or back pain or diabetes insipidus. Always try to be more understanding of adolescents. There are unique people, and different studies show that there are more delayed diagnosis. And I think because of that age group tendency to avoid talking to us, and we don't want to talk to them, we're happy if they don't complain. So take them seriously when you see them. I like to, the second part of my talk, I like to share real cases. Almost all these cases are cases I've seen or I got involved in. So these are real life cases, and I will show you what I mean about the theory that I just presented. So I like to make the talk half of it theory and half of it practical. Because I think as physicians, when we see our deficiencies affect patients, it makes it more serious of an issue. It becomes too personal for us as physicians and as humans. This is one of the interesting cases. The patient at the age of 5 started having headaches. It woke her up at night, sometimes at school, and it lasted for 2 years the same. At the age of 7, she started to have a stiff neck. And she started going to the ER to be seen. And at one point, she had an X-ray of the neck and the sinuses, and both within normal limits. And she was assured, and she was told that you have a stiff neck, and use an airplane pillow, which she, of course, she improved. Again, if you remember the causes of delayed diagnosis, patients can wax and wane the symptoms, and patients can have improved symptoms. It does not exclude the brain tumors. We were always taught if you have a brain tumor, it should continue to grow and it should continue to get worse. It's not the same, because again, most of these tumors are low-grade tumors. At one point, she traveled and she forgot her airplane pillow. Of course, her symptoms got worse. That emphasized the diagnostic imprinting, the first case that the diagnosis she was given. That emphasized it. Her headache continued, and the school now will call. She had neck pain. Just think about it, how many red flags this patient had with the headaches. She became tired and sleepy. She had nausea and vomiting and tired all the time. Still, no thinking of a brain tumor. She was seen by an ophthalmologist who told them she needs glasses, but no explanation of the headache. She was seen by a neurologist who diagnosed her by migraine, but no treatment was given. By the way, migraine is one of the big waste baskets we use when we don't know what we're dealing with. And I think we need to be aware of this. One of the studies showed that 33% of children diagnosed with migraine do not fit the criteria. Again, I'm not saying migraine does not exist. Again, I'm not saying every child with migraine should get MRI. All what I'm saying, good history, good physical, and good follow-up. Educate the patient. If the migraine treatment does not work or the migraine is worse, come back. Or if the migraine starts off so be associated with other symptoms, come back. A few weeks before diagnosis, she went to the ER 3 times. She was twice called stomach virus. Again, this is another waste basket, viral infection or stomach virus. Again, how many viruses in GI viruses will last for many weeks or many months? At one point, the family, I don't know, I never asked them if they lied about it or they were, it happened. The patient had a kick on the head, and that's what prompted the CT scan. And I'll show you the CT scan, but I want you to think for a second. If this triad, the patient have the morning, the vomiting, the headache, and I think papillary edema at one point. But if the patient had these symptoms over 2 weeks instead of 2 years, I think most of us would have done imaging for this patient. You don't need to be a radiologist. I love this term, the eye does not seek what the mind does not, the eye does not see what the mind does not seek. I was taught this in one of my campaigns about delayed diagnosis in Alexandria, Egypt, and I love it because it's so true. Again, this child got a diagnostic imprinting. She was given a diagnosis, and that's what everybody thought about. This is another interesting case from Jordan. The patient had 4 strabismus surgeries before the ophthalmologist thought maybe there is something wrong. I need to image the patient. Look how big is the tumor. Again, both patients survived long term, and to my knowledge, they're still alive, but the quality of life, I think it's really not the best. This is a very interesting case. This case, she was at the age of 8 months, she had unilateral nystagmus. Different people told the father, different physicians, that it's okay to have ocular symptoms in the first year of life. And I think that was our old teaching, but the father was not a duckling and he did not accept the diagnostic imprinting his daughter got, and he insisted on getting an MRI, and look how small is the tumor compared to the other cases. So this father was a better physician than the other two, or the coming ones I will show you. This is another sad case. It shows how when we give a diagnosis, it sticks. The patient started having the right pinky curving inward. Then more fingers, then the hand, then the arm, then the leg. She was shuffling like a 70-year-old who got a stroke, according to the mother. This lasted over 3 years. She was given a diagnosis. This is the way you hold the pencil, and everybody stuck by it. She was seen by a neurologist and a pediatrician. The neurologist ordered an EMG. Of course, it was normal. The family were assured. Finally, a nurse practitioner who was not a duckling and did not accept diagnostic imprinting, and she diagnosed her with an imaging. And this is not the MRI, the tumor, all of it. This is the radiation planning for this child. And again, the child is alive, but the quality of life is significantly affected. She will never be a very productive member of the society because of her deficits. This is a very interesting case. A 4-year-old who was diagnosed with malnutrition, failure to thrive, a typical diencephalic syndrome presentation. The patient got everything in the beginning before MRI. And you can see how big is the tumor. It took them, I think, 3 years to diagnose this patient. And this patient is from Chile, another country where there is amazing access to primary care. It's really not about access to imaging. It's not about access to primary care. It is about education. Physicians are the problem and not the patients here, or the healthcare system. We need to change the way we teach brain tumors. This is another failure to thrive case. Again, I talk a lot about it because we see a lot of cases of diencephalic syndrome delayed diagnosis, but also because its counterpart in young adults, especially females, is anorexia nervosa. So I want to create awareness about this. Again, my objective is not to start immediate imaging. I don't think you need to do immediate imaging, except if there are signs of increased intracranial pressure, nausea, vomiting, papilledema, or there are acute focal signs and symptoms like the patient who was having curving in her fingers and the arm, because we know the motor strip controls different parts of the body. So when there is a focal neurological sign or symptom, we have to take it more seriously. Keep in mind, most of tumors are low grade. So if there is no increase in intracranial pressure, there is no need to rush for an MRI. Diagnosing a pilocytic astrocytoma or a ganglioglioma now or in a few weeks or will not make a difference. So take your time and before you order imaging. So this patient, it took her a while to be diagnosed. She had 7 months history of failure to thrive. You can see how much workup she had. The family were asking for imaging. The patient, they were about to start TPN for her. They started her in NG feeds. She saw everybody except imaging. The family asked for imaging, and finally someone at night ordered an MRI, and this is what the tumor that showed. Again, low-grade tumor. This is one of the saddest cases I've seen, and it emphasizes why I'm against immediate imaging and unnecessarily imaging. It makes me nervous because this patient was having seizures since the age of 5. She had a CT scan that was reported negative, and everybody stuck to this. For the next 12 years, she saw every neurologist or neurosurgeon maybe in Jordan, but because she was diagnostic imprinting, labeled with the diagnostic imprinting of negative CT scan, everybody focused on the seizure. When she was diagnosed with a ganglioglioma grade 1, you can see in the tumor in the CT scan, she was acting at a level of elementary school, because she missed half of the school year, and when she's in the school, she was drugged, so she did not get good education. She survived. This is a very interesting case. At 2 years, the child was walking funny and have soft voice. The family were given a diagnostic imprinting and were told all 2-year-old walk funny and have soft voice. Unfortunately, the father did not let the mother see her parents for 5 years. So they disappeared, and the grandparents were not in the picture for a while. And finally, luckily for the child, the mom got divorced and she went back to her parents. And when the grandmother saw this child, she was shocked. She told me, like the other patient, he was shuffling like a 70-year-old with a stroke. And she said, that's not normal. She took him to a pediatrician. Interestingly, the pediatrician was not worried about the symptoms that were happening over 5 years, because these were chronic symptoms. He was more worried about the recent hearing loss that the patient had. So he referred him to an ENT who was a good internist and ordered an MRI. And if I show you the rest of the spine, the tumor was all the way to the lower thoracic spine and upper lumbar. The patient survived, but the quality of life is miserable. This 9th case is very interesting because of the psychiatric diagnosis the child was given. At the age of 10, the child was diagnosed with ADHD. And again, I'm not saying every child with ADHD should get imaging. I'm saying it has to be given a diagnosis that has to be given by an expert, but not by someone like me or a general pediatrician who doesn't deal with it on a regular basis. At the age of 12, more psychiatric conditions like obsessive compulsive disorder, depression, and anxiety. And the patient was started on Zoloft. At the age of 15, she started having visual symptoms and worsening headache. And finally, an imaging was done, and it showed a left cingulate gyrus tumor. As some of you may know now, so one of the treatment for OCD is lobectomy for the cingulate gyrus region. At least that's what I was told by our neurosurgeon. But the point I want to make from this case, again, I'm not saying every child with psychiatric condition should get imaging. All what I'm saying, every child deserves good history, good physical, and good follow-up before we label them as a mental condition. Once you're labeled with this diagnostic imprinting of a psychiatric condition, it's really extremely hard to get out of it. And I cannot emphasize that we need to be careful. When I was a medical student, we were told that you do not give a psychiatric diagnosis before you do spinal tap to exclude syphilis, which used to be called the great mimicker, because it's in the stages, it can mimic anything, or a brain tumor. And one of my least favorite diagnoses are oppositional defiance syndrome and convergent disorder. I feel we use them to label children who don't conform to our standards. Not the imaging of this child. And it's very interesting because some of my psychiatric colleagues, when I give these talks, they ask me, do you know how much it costs to do MRI? And my response usually, how much it costs to put someone on Zoloft. I'll give you an example, part of our change in the healthcare system in the United States. Anyone can order Zoloft without any psychiatric degree or any experience background. But a drug like vinblastine or everolimus or meropenem to control infection can need a special permission to order. And if you look at the toxicity profile of vinblastine or everolimus, I think it's much less than Zoloft. And I think that's an unfortunate problem in the healthcare system in the United States. I'm sorry for the bad imaging. This was a consult by email. But the patient, you can see, was given the diagnosis that I don't like, convergent disorder, and the patient had a lot of red flags. I'm not aware psychiatric conditions in general should have focal neurological symptoms, and they encountered us. Finally, someone decided to do imaging. This is not a case of mine. This is a case I found in the literature based on one when I was working on our paper on torticollis. And it's a very interesting case. I'm not going to talk about it a lot, but you can see how the patient was labeled. Again, diagnostic imprinting, and nobody believed that child. Even the child was seen by a neurologist and was given the diagnosis of convergent disorder. And finally, new fresh eyes saw the patient. The scoliosis was worse. And it took them forever to diagnose the child. I believe this child died, if I remember correctly. I promise you, I know this child case is 40-year-old, but I really don't think that things are getting much better because it's about education, and we did not change our education. I want to, again, emphasize psychiatric issue quickly, and especially eating disorders, because we label a lot of young girls with anorexia nervosa. And I think, I believe this diagnosis exists, but I really think we have to consider good history, good physical exam, and proper imaging before we label a person for anorexia nervosa, institutionalize them, and put them on TPN or feeding tubes. Again, it goes back to good communication. Do not order the wrong imaging, and if you order imaging on a child or a woman with anorexia nervosa, please communicate with the radiologist to look at the midline. Otherwise, they will look at the for big masses or strokes or bleeding, and they will miss a tumor in the midline. I've seen it happening many times. This is an interesting case. It was not really delayed diagnosis to a degree, because I think the child was treated properly, but this patient had chronic back pain for 1 year. No other symptoms, nothing else. No urinary symptom, no scoliosis, nothing else. But because he was seen by a neurosurgeon who deals with St. Jude, they thought of tumor, and they did the spinal MRI. So the patient, the neurosurgeon, did not follow the other physicians and did not follow the diagnostic imprinting. And again, it goes back to the point I said. That's why a lot of spinal tumors are delayed diagnosis the most in children, because we think of a chronic back pain is okay if there is no other symptoms. And the patient had mixed papillary ependymoma, which is a low-grade, grade 1 tumor. I like this theory. When I was a student, a resident, and we used to talk about it. And I think that's one reason we have to consider early diagnosis, not only in the brain tumors, because there are many other cancer size of the tumor impact, even if there are no metastases, impact survival and has chances of metastasis. So I think we owe our neurosurgeon to do a good job and sending the patient with as small a tumor as possible so they can do gross resection and cure. And then the patient will not need chemo or radiation. This is our paper. I'm going to go quickly over it on psychiatric condition. And one of the interesting things, we found that, as I mentioned earlier, eating disorders, anorexia in low-grade gliomas, hyperphagia in craniopharyngioma. Again, most of these patients, we have a normal exam, and we have to admit it, very few of us will do visual field. So if you don't do visual field, these patients will be labeled as normal exam and nobody will think of a brain tumor. Keep in mind, the brain tumor can manifest as an endocrine or eating disorder. This is a torticollis paper we published recently also, and interestingly, there are some of the patients that even rehab services and improved. Again, diagnostic label. They were told this is idiopathic torticollis. I'm going to share with you some of the quotes from UK, again, not developing country, from UK, of patients and families. And that's what prompted the Head Smart, I think, which is really an amazing project in UK. And again, this is a female. As I said, females and poor were treated the worst or misdiagnosed the worst. This is another woman. This is an acronym I came up with, and I hope it improves the problem, and we're trying to promote it through some educational project, low or pay, and it will. I hope it will help ER physicians or primary care physicians to remember what to think about for brain tumors. I like to share this case. I like to brag about it because this was a medical student who listened to one of my talks, and she had this poor family who traveled hours to see her from a rural area in Turkey, and it was at 1 a.m, and she remembered what I said about believing the parents. She said, I did a good exam. In fact, she did a better job than me. She said she developed her own 5 to 10 minutes in neuro exam to exclude things easier, and she was able to diagnose a brain tumor, and she was so proud of herself. I love books, and this is a book was shared by one of my colleagues in Singapore, and how a whole people were given a diagnostic imprinting. And it's a very sad story, but how this child and her family were given a diagnosis or labeled, and nobody believed them many times. But something I recommend to read. It may help you to be a better physician or more compassionate. It for sure helped me to do that. I'd like to share this picture, not to brag only, but to give the final message. This is swimming with the great white shark. I was safe, me and my wife, and I had this camera with 27 pictures, and I was taking pictures non-stop. And I was very lucky, and I got a picture of the shark coming out. The point I'm making, in addition to bragging, is that I don't want my talk to emphasize more imaging, because this will be damaging. I want you to be a professional photographer. You can sense the waters and know when to take the picture before the shark comes, and catch the shark with the least imaging possible, and not be like me and be an amateur like me and just take 100 pictures to diagnose one patient. Again, most of tumors are low-grade tumors, and there is no problem with delaying diagnosis a few weeks. So be careful before you order the wrong imaging. These are cureforkids.org is an amazing resource, and I have different talks on this issue. And also, this is my email. Please feel free to email me to discuss this further. And I'd like to share my family. I owe them a lot. My wife is on the left and me on the right. And my daughter got accepted in medical school, so another bragging I'm doing. And this was in the white coat ceremony. Thank you again for having me to present to such amazing group, and I hope this will help improve this topic.